This line graph maps a specific failure in the American healthcare system. Between late 2020 and early 2022, the Household Pulse Survey found that a steady 9 to 12% of the U.S. population needed mental health counseling but never received it. These figures represent a massive, multi-year data collection effort, coordinated by the CDC, the National Institutes of Health, and the Substance Abuse and Mental Health Services Administration. Across the country, the divide between need and care is stark. Only about 48% of people requiring mental health services actually receive them. This vacuum is maintained by three specific physical barriers: the high cost of treatment, a lack of available providers in many regions, and the enduring social stigma of seeking help. We are witnessing a structural failure in how healthcare is delivered. The challenge ahead is building a functional bridge between vulnerable patients and the professionals who can treat them. Telehealth became the primary technological intervention used to solve the geographic and logistical hurdles of traditional therapy. Data from the NIH shows the intervention works. Over 75% of telehealth users explicitly agree they received good care. Common fears appear overblown, with the vast majority reporting that technology or privacy concerns did not hinder treatment. If remote, human-led therapy is effective, and patients are satisfied with the results, why do federal trackers still record millions of Americans in distress without any help at all? A functional technological bridge is of little use if massive portions of the population remain blocked from reaching the on-ramp. We can begin to see where that blockage occurs by looking at the geographic divide in mental health treatment rates. There is a massive discrepancy between states. In Vermont, treatment rates exceed 32%, while in Florida, that number falls to roughly 18.5%. These gaps reappear locally. Metro areas use telehealth significantly more than rural regions. Racially, Black and Asian populations report lower usage than white and Hispanic groups. Economically, usage forms a declining staircase, with lower income brackets seeing the sharpest drop in access. Your zip code, your racial background, and your income bracket serve as the actual walls keeping patients out of the system. This crisis persists because our resources and infrastructure are maldistributed. We have effective treatment modalities. We simply haven't built the roads to reach them. To bypass these demographic walls, the tech industry is now pitching large language models to act as 24/7 autonomous therapists. The appeal is obvious. It promises infinite scalability at near zero cost, theoretically closing the access gap through sheer automation. But effective therapy relies on an emotional connection. The federal data showed that patients value the quality of the human encounter, a quality that machines cannot replicate. Recent institutional research found that these models fail basic clinical safety standards. When tested, they frequently express dangerous levels of stigma. In clinical testing, models like GPT-4o and LLaMA 3 expressed severe bias against patients with schizophrenia and alcohol dependence. While human therapists respond appropriately 93% of the time, these models lack the non-judgmental core required for healing. This logic flowchart illustrates the flaw of AI sycophancy. Because these models are programmed to comply with users, they often accept delusional inputs in a loop, failing to execute the clinical redirect needed to save a patient from a manic or psychotic thought process. A system built to agree with you is incapable of challenging a harmful reality. Resolving the crisis mapped by the federal data requires us to invest in the infrastructure that pulls vulnerable populations through demographic barriers. We must connect them with real human professionals rather than attempting to automate empathy with code.